It took a while for people to start using that test, and yet it's so important. It can explain a lot, and most importantly, it's treatable.
When my patients see you and you would do a Hebrew prayer sometimes for some of them, if I tell them, don't forget to ask him to do a prayer, the energy comes through. All of these conversations have been a combination of holistic physician or Dr. Mars or Kelly Beck, the Western science, but it is the passion that drives the whole train.
Yeah, I just want to add to this that, and I'm sure you'll ask me a lot of questions about that, but maybe just before that, as I was traveling through that journey of development, scientific and technological and whatnot, in IVF over the past 45 years, soon after that started, different disciplines began to develop alongside the scientific part of it, so to speak. And those included support groups, psychological groups, acupuncture, nutritional, and whatnot. And those were sort of spread out and sort of spotty different developments that were not cohesive until Danica came along.
Oh, no.
Danica Thornberg,
that was like 2002, I think.
You definitely changed it. You are a leader in that respect, that you actually took all those disciplines and packaged them into one cohesive and comprehensive discipline where patients can just start and finish everything in preparation or alongside the treatment. And my experience with that, I was a little skeptical at first, but my experience with that has been that patients are in a much better place when I see them coming from your place to my office. They are much more confident, they're much more relaxed, and that contributes a lot to the success, in my opinion.
100%, I believe that. And I've seen that, I have 30 different reproductive endocrinologists that I work with. And there's a certain kind of personality and a certain type of case. And those are the ones I know to send to you. You know who they are. They're a little bit older. They have fewer eggs to work with. And they are nice as can be and anxious. And I know that you're going to take care of them, and you consistently do. And then I love that you acknowledge that I have helped to prepare them for you to make it such a short-term, seemingly effortless, but we know it's not. It's not at all effortless.
Far from that.
It's not something that we just practice and do the same thing. Every one of the patients is different and has a different story and a different set of circumstances, and it's such nuanced medicine.
Well, what would be the connecting fiber in all those cases is that they're all so-called tough, difficult situations. That would be patients who are in what we call advanced maternal age, or patients who have what we call diminished ovarian reserve, who have been deemed by other places sometimes as incurable, untreatable, or intractable, and have been told that they cannot succeed in conceiving using their own eggs or sperm. And we're instructed to use donor eggs or surrogacy, maybe sometimes prematurely, only to find in connecting with you that maybe there's still another way for them to succeed if they just chose a certain path. And in many cases, as you know, that was the case. They conceived.
Oh, my own case, I don't know if you know much about my story.
Please tell me.
When I was 10, I saw an infographic of IVF, and it inspired me from then. But fast forward 20 years later, and I graduate acupuncture school, and I should be so healthy. But turns out I had diminished egg reserve. My FSH was 21 points, and I was 31 years old. I had a blocked fallopian tube, and I had stage 4 endometriosis. And I had no partner. I had to convince a surgeon to do endometriosis excision surgery on me when I was almost 35 years old, based on severe pain, vomiting. And so I had to be the detective on my own case to figure out, what can I do with this? I have all these herbs. I've helped all these patients. What do I need to do? And how do I connect and communicate with medical doctors to be taken seriously for this profession and as an empowered patient who will get her needs met without a partner? So it kind of touches into all of these patients' predicaments, and I can be a person who can help them become empowered on the path to ask certain questions, to ask for certain procedures, to think outside the box, to listen to herself. So when I refer to you, because I've seen you trust your hunches so many times, it just feels resonant with the way that I practice. So like, I may think this patient needs more care or she needs more time together. But you say, oh, you're ready for IUI. And I just zip it and I say, okay, well, let's support that. And then here we have twins, right? We have one story immediately is coming to my mind. You may not even remember her, but she came to me from another doctor's office. She was 41 years old and she is Latina, and she had been missing some periods. She had an ultrasound and it looked like she didn't have any eggs. And I said, I don't think that's the case. I think you have some eggs, but I'm just thinking we need to explore blood sugar, is my hunch, based on her ethnicity. Sure enough, her A1C was elevated, insulin was elevated, and it was suggesting, and cholesterol was suggesting she was potentially diabetic. So we got fast and furious, clean up the diet, put her on herbs, and a change of doctors. You are the doctor that I sent her to. I mentioned this case on another episode, but you are the one who gets the credit for this because you did the ultrasound and you saw that she had nothing. She might have had one follicle, and you did an IUI. It was unsuccessful, but the second IUI is resulted in boy-girl twins. Those are the best stories, right?
I actually remember the case. I'm a little surprised that I remember most of the patients that have been to the office, especially the ones with difficulties. After more than 10,000 patients, you would think I would forget most of them. And I do. The ones who come and get pregnant easily, I don't remember. Mm-hmm. But the ones who have difficulties and some long story typically make an impression, and I tend to remember them. Mm-hmm. Well, that leads me to another thing, and that is, okay, those patients who, for example, have high FSH or low AMH level, as you described yourself and others, and are told, therefore, okay, look, your AMH is too low or your FSH is too high to get pregnant based on a blood test. I disagree with that approach. I think that you look at the whole person, you don't look at a single blood test or even several blood tests to decide whether the treatment has a chance to work, or you need to look at the whole person. Sometimes blood tests can be abnormal, but I do an ultrasound and I have a feeling that this is not the case here. There's discrepancy. It's not unusual for blood tests to not tell all the truth. So we need to look at the whole integrated picture. I'm not surprised you call your center, Well People, Integrative
Healing
Center.
Mm-hmm.
Well, it's integrative or integrative. I think that's important to emphasize that. All aspect of the person, the psychological aspect, the nutritional, the socioeconomic, everything, and the blood test and ultrasound and whatnot. And once everything else is analyzed, many, many times, the outcome is completely different from what we imagine just based on the blood test. There are all kinds of options available to those women, even with a very poor ovarian reserve. There is natural IVF without medications that works many times with those who have a single follicle.
So natural IVF means low-dose medication?
No medications.
No meds. Okay.
I have many, many such stories of women who had no follicles, so to speak, on ultrasound and blood tests were poor, and so forth. And we simply followed their natural cycle until a follicle emerged. And then we followed that follicle until it was ready. And the only thing they needed was that one trigger shot. No medications otherwise. Of course, the usual prenatal vitamins, baby aspirin, whatnot, but no injections of hormones. And then they receive the trigger shot, a single trigger shot. And then we get the one egg that they have. And many times that one egg is wonderful. It's just they don't have the numbers, but they have the quality. So the one egg could be excellent, and it fertilizes, become a beautiful embryo. We don't even bother to freeze it. We don't bother to test it. We just simply transfer it, usually after 3 days, sometimes after 5 days. And many of them get pregnant successfully. Remember that most pregnancies in the world occur in a natural cycle with a single egg. Mm-hmm. So why shouldn't this one work? Mm-hmm. So I'm a big believer in natural IVF where there's no other choice, or mini IVF where you give a limited amount of medications to other women. There are adjuvants that can be given to encourage that. I'm sure you're more familiar than I am even about DAGA and whatnot, the CoQ10 and many other antioxidants that can help those women. So before one agrees to surrender because of some opinion given by somebody, I think they should consider a second or third opinion. And many times the outcome can be completely different.
Mm-hmm. Right. You are my second and third opinion go-to guy. And
I hope I become a first opinion one day.
Well, given the proximity of our clinics, but it puts me in an awkward position, but I keep seeing the same thing where unfortunately they're told too much of a poor prognosis too soon. And there are a lot of younger physicians that want to do just the new textbook and go for the number of the follicles and high dose medications and certain protocols that are I choose the younger physicians that understand the old school protocols that have been tried and true and that still work.
Right.
So,
well, in many cases, it's counterintuitive, but low-dose medications might work better than high-dose. For example, older women, I don't know, when I say older women, people have a picture of somebody in their 50s or 60s, but in our profession, we tend to put the label of AMA, Advanced Maternal Age, sometimes in women in their late 30s. Inexperienced doctors sometimes believe that advanced maternal age means that you need to give a person large amount of medications to elicit better response, and there's nothing farther from the truth. In fact, after a certain age, they benefit from lowering the amount of medications, allowing the follicles to develop slower but in synchrony, rather than just pushing them hard and getting one of two follicles or eggs to develop, leaving the others behind. And so those kind of understanding comes from experience and from having worked with this group of women for a long time and seeing the results of different treatments, as you mentioned yourself.
Mm-hmm. Right. We see them, and they do have different stories, but they do sort of have some similarities. Their nervous system is upregulated, whether they're 33 or 43, they're really in an upregulated state. So first we have to get their nervous system to calm down, and then for them to become more open-minded to maybe a doctor change. And as I understand, those follicles have receptors, and those receptors can only hold so much stimulation hormone. So the extra medication isn't doing anything except potentially stressing out the nervous system and costing them more money. So that's another reason why they like to go to see you. It's less medication, right? So less money.
Yeah, but I think, not to mention the economical aspect of it, everything else also benefits from it. Stress hormones are not necessarily beneficial, so they better be in a relaxed state when they do that, and that's where your role is. Acupuncture has been beneficial, especially around the time of embryo transfer, I find, where when they get the acupuncture and they're relaxed, the uterus doesn't contract at the time of transfer. All those things do make a difference.
Right. We should talk about how we first met.
Okay.
Because
You have to remind me now.
Yeah, well, I'll jog your
old.
memory. Right. So it was 2001 or 2. And ironically, the building where you have your transfer center is in the same building where I received my first acupuncture session. Isn't that funny? So I pulled in there at 6:30 a.m. on a Christmas morning to assist this couple in doing acupuncture before you were going to put the embryo in. And I had never done it. It was like pitch black outside.
That was the ART.
Yes,
ART
the lab.
The lab.
Mm-hmm. Yep. And it was dark and I was tired, but I was so upregulated and immediately perspectivized on how hard all of the REs, especially at the time, were working, because you do the transfers first thing early in the morning, and then you do retrievals, and then you do consultations, like the 7 days a week. It doesn't matter if it's Christmas Day, the embryo is ready to be put back in. So the patient was misinformed. We weren't supposed to get there until 7:30. The ART lab was locked. We just sat in the hallway there having a conversation, and they were so anxious, and with anxiety comes a need to talk. So by the time we got in and I did the acupuncture, they were talked out, as was I. We put the acupuncture needles in, and we may have passed in the hallway, or maybe I got to wave and say hello. And I was like, I wanted you to know acupuncture will really make a difference in calming them down, and they're taking a Valium. Like there's something going on, but I just like ran out. I was so shy, but somehow our patients kept hiring me to go provide that outcall, and they kept succeeding and having good outcomes. So I do remember, though, that somewhere something happened with some of my acupuncture colleagues, and you had to put a temporary kibosh on acupuncture at the time of transfer. And it's water under the bridge. I don't know what it was, but I reached out and wrote a letter. You probably thought, who is this woman, this renegade for acupuncture at the time of transfer? But I just wanted to say, like, I think it makes such a difference that we can't let it go away.
I was skeptical at the beginning. I admit that. And I sort of warmed up to it over time, yes.
Yeah, but I think, it's one added thing at an important day, and you're trying to do the most important job, the culmination point of putting in that normal embryo that everybody's worked so hard to create. So if we have to then include this time in the schedule for acupuncture, and I'm in the room, but do you remember how it was? Because I've attended hundreds of embryo transfers at different clinics. We have me on one side of the patient, her husband on the other side. Then there's the nurse, the embryologist, and the physician.
All in that little room.
All in those little transfer rooms. So, we've come a long way. COVID said no more acupuncture at the time of the transfer. And I was starting to think, with my patients who I've worked with, they're ready enough. Like they can have acupuncture the morning of and go in, so that's changing. But the way that some of the research studies inform the protocols and the decisions, right? So there was a study that was done that showed that acupuncture at the time of embryo transfer will change the outcome. But that was a protocol of acupuncture points that wasn't individualized for the particular case. So I had this idea that if we've already optimized the woman, it's not that last minute set of points that's going to make a difference. It's that she's prepared. So I just want to say that because I know that the more we can relax the women going into the transfer, the better
no question
the outcome.
about it. Yes, that's why I mentioned before. Also, we emphasize at our Center for Fertility and Gynecology, we emphasize the holistic approach to the patient, not just a lab test here or ultrasound there. I think that putting a patient at ease from the very beginning, from the initial consultation, I see the couples coming in, sitting down, very tense. They're going to see a doctor. The doctor is probably going to be very, very serious and very authoritative, and they're already tense about the encounter. And I feel it's my obligation, not just to give them information, but also to make them feel like, actually, we're just a team that works together to solve a problem. I'm not here to give you orders or to tell you what to do. I'm here to participate in your journey until you get what you want. And in that respect, I'm more of a friend than a authoritative figure. And I feel that that's important in relaxation. I feel how they take a deep breath very soon after the consultation starts, and the attitude changes. The husband usually cracks a joke at that point, and everybody is relaxed. And that's quite important in the treatment beyond what you do, because they can benefit from everything you do, and then they go to the office of the doctor, and all that can fall apart if they don't get the right attitude.
Right. I can attest to this, because when I was earning my doctorate, you were one of the people that I chose as a mentor, and I got to observe you for a full month. And some of your patients allowed me to sit in on new patient consultations in your office. And I got to see you're very disarming, very personable. And where you start the conversation is meeting them where they are and what's led them there. And then you send me a copy of the notes that you've taken. And it's similar to the way that I interview my new patients. I want to know how they met their husband, which seems like kind of a weird thing, but it's important because that was also a challenging process that was left to fate, that seemed too hard at the time, or maybe they were getting too old or whatever, that was going to be too complicated. So if I ask them, how did you meet? They immediately smile and they remember that worked out. And that's how I'm able to disarm them. Right. So
good point to remember.
Yeah. We're sharing secrets here. The big secret that drives me to send to you lately has been the Intralipids infusion. And before we even go there, please tell me your thoughts on the immune system and the immune response, because here in Los Angeles proper, there's not very many people who are willing to see that the immune system is an important part of this. My background is in HLA. So that's the immune system. It's a gene on a chromosome about the immune system.
Exactly.
So I sort of understand what's going on, but I'd love to hear what you think about this.
So to not go into too many details and make it too scientific, the immune system has two components that are major components to it. One is the cellular immunity, and the other one is the antibodies, essentially, that we all hear about. And they work in concert. So the antibodies are the major part of the immune system. They are designed to reject any invasion by foreign bodies, viruses, bacteria, and so forth. Unfortunately, the antibodies take about 3 days to develop from the initial contact with a foreigner. And during those 3 days, the body would have not been able to withstand the invasion unless something repelled the invader, even though not as efficiently, but at least to keep it off until the antibodies form. And that something is the natural killer cells. So the natural killer cells are not specific to one or the other antigen, But they, in general, whatever is not part of the body will be rejected by the natural killer cells until the antibodies take over. And what happens in pregnancy, interesting enough, is you have a foreign body. The baby is 50% foreign. And the immune system should have rejected every pregnancy because it does. That's the job of the immune system, is to reject everything that's not self. So how come the baby is not rejected? Well, it turns out that a lot of things happen. The helper cells and so forth. But what I'm talking about here now is about the natural killer cells. And the natural killer cells activity tends to drop as the pregnancy occurs in nature. And for whatever reason that happens, but the natural killer cells are unable to reject the pregnancy because their activity drops mysteriously as the pregnancy starts. What if it doesn't? What if the natural killer cells behave as they normally do? They will reject the pregnancy. Mm-hmm. And then what you will have patients who get pregnant and lose the pregnancy and have what we call recurrent pregnancy loss. And as time goes by, it gets even worse, and they get a chemical pregnancy, which is such an early rejection that they never get to the point where there's a sac. It's just a positive pregnancy test, a blip, and that's it. And even later, they may not even know that they got pregnant because the rejection happens so early that they just think they were late on a period. And all of a sudden, when I investigate with those patients, yes, I noticed that I always had regular periods, and lately there have been many periods that were late. And those were actually pregnancies that were rejected early. So that aspect of the immune system is very important to recognize and to treat in women who either have recurrent pregnancy loss or who have not been able to get pregnant for unknown reasons, what we call unexplained infertility. And there are many aspects of that need to be investigated. I'm not limiting it to that natural killer cells. We checked other things. We check antibodies, of course. We check the shape of the uterus to make sure there's nothing wrong with the uterus that's causing miscarriage. We check the husband's sperm. We check infections and so on and so forth, hormones. There's a lot of aspects. But when everything else comes back normal, what are you left with? The natural killer cells. So why not just check the natural killer cell level and find out if that's the case? Turns out that's not so simple. If you were to check the natural killer cell activity in a non-pregnant state, that doesn't tell you whether they are going to go down or not when the patient gets pregnant, correct? So it tells me nothing about the pregnancy stage. And if I decide, okay, I will sacrifice one pregnancy and test them while the woman is pregnant to see if then the level goes down. And if it shows that the level goes down, it only tells me that it goes down in the blood. It doesn't necessarily tell me what happens in the uterus. So those tests cannot be accurate or predict actually what will happen with natural killer cells. So the solution is, if everything else does not explain what happens, just treat as if you found out that this was the problem. In the past, the treatment for patients in such situations involved giving them what we call IVIG, intravenous immunoglobulins. That's the same substance or medication that's given to people who get transplants to prevent rejection. Mm-hmm. Well, it's okay for those people, but you take a woman who you don't even know for sure that this is the situation, give her something that is, number one, extremely expensive in the thousands and thousands of dollars, has a risk because it's a blood product, so it has a risk of transmission of unwanted pathogens. I don't see it as justification for giving IVIG.
Mm-hmm. It's very controversial.
It's controversial. And when the solution was IVIG, I was not subscribed to that. Mm-hmm. For those reasons.
Mm-hmm. Plus, I think it was not available here in the States. They had to travel to Tijuana.
Oh,
That's
you're
the
talking about something else now.
Lit procedure, right?
Yeah, no,
Lymphocyte.
you're right, but it's a different situation. That has to do with what you had, the HLA.
Right.
The HLA was a situation where the husband and wife had too much immunity in common, and giving white blood cells from the husband to the wife seemed to be ameliorating the situation. The FDA banned it. So people began to go to Mexico to get it.
That was called lymphocyte transplant, something. Yeah, lit procedure. I just remember it going with the IVIG.
That's true. So some people were getting both. But the reason for going to Mexico was not the IVIG. IVIG is available here.
Okay.
But the injection of white blood cells
lymphocytes
from one to the other was not allowed. And so that's... The IVIG was not acceptable to me for this situation because it was not clear. It was never clear that you actually need to give it. And if you give something so significant as IVIG that has risks and expensive to somebody who is not absolutely in need of it, it defies the whole idea of medicine, which is first don't do harm and so forth. And so when a potential patient called me from San Francisco 15 years ago and told me, and the reason she found me was because her sister was my patient, successful. And so she told me, why don't you call Vermesh? She called me from San Francisco, giving me her story over the phone. And her story involved failure after failure with in vitro. She was young. She was 34. She failed many times with in vitro, with embryos that were produced from her eggs that were tested normal. And then she gave up on that and went to egg donation. And that failed too.
And that's telling you something.
And she asked me, is there anything that you can offer me that they did not offer me here in San Francisco? And I checked the record and they did everything possible. And that's when I began to do research.
You mean like Lovenox and prednisone?
Oh, they gave her all of that. The whole package that you can imagine, immunological testing and everything. And my first reaction to her, no, I cannot offer you anything else, but let me check on this. And I began to rummage through the literature to death. And finally, I came across not even a paper that was published. It was a presentation at a meeting by a British doctor who had given Intralipids. And he felt like it was helpful, but when he did the statistics, he did not reach significance. So he sort of gave up on it. And when I looked into that a little bit more, what I realized is maybe he was onto something, but he did not give enough of it. He was giving 2 grams of intralipids, and I felt like this was not sufficient. And intralipids was available in the market. It was just off-label in this case. And it was available in concentration of 20%, which is essentially 20 grams, 10 times as much as that doctor was giving. I did not hesitate much in giving a large amount of that because intralipids is fatty acids from soy. It is a completely natural product. It's not a chemical or something unknown. It's essentially like giving tofu to somebody.
So if the person has a soy allergy,
if it's
then
a soy
it's
allergy,
problem.
yes, that would be the only problem.
Okay, that was always my question.
Although I had a couple of patients with soy allergy that I give, and nothing happened to them either.
So it might be that good.
I think it's at the level of the gut, and we are giving it to the vein. So I don't think it's elicited the same response when given IV as it would be if they were ingesting it. I called back that person. I told her, look, there's something I can offer you, not proven, never tested it before. You'll be my guinea pig. She came over. I told her, bring all the embryos you have from San Francisco. She still had a lot of embryos. And we put
Were they tested, genetic tested? I know you said they were donor egg embryos, but do you know if
they were tested? And the reason they were tested is because the reason she did the in vitro was not because of infertility. The reason she did in vitro is she had a child born with genetic abnormality, and she had to test.
Okay.
Well, her own she had to test. The donor embryo, she did not have to test. She brought the embryos to my office. I transferred one of the donor embryos, and she got pregnant immediately, successfully, and had a healthy child. And then she called me and said, I would like to have one more child. And I said, why don't we try this time with your own embryos, not with the donor embryos? And we did that, and she got pregnant again. So she had 2 successes out of 2 attempts, and that gave me a big psychological boost.
Mm-hmm.
And I used that protocol for women, not just like her, but I expanded it to all those things I mentioned to you, to women with unexplained infertility, with recurrent pregnancy loss and whatnot. Now, after 15 years and over 1,000 patients that received Intralipids, I'm totally convinced that this is a major, major contributor to success that I have, apart from everything else that we discussed before.
Mm-hmm.
And so it's quite simple. The patient has the embryo transfer, and at the same time that the embryo is transferred, a needle is put in the vein. They get the intralipid by a drip over a period of 1 hour when they're supposed to rest anyway after the transfer. And if it's successful, which is usually the case, they have to repeat this course of intralipids a couple of more times in the first trimester of pregnancy.
So do you find other reproductive endocrinologists are using that protocol too?
I see a resistance to it.
Me too.
And
I don't
cannot
understand.
for the life of me understand why the resistance. I've seen a couple of centers in Southern California that have begun to give it also. On the East Coast, I had patients who are from the East Coast. They could not find one, and they had to fly all the way back to my office for the 3rd course, all the way from the East Coast, because they couldn't find one place.
And so, do you have any idea what their hesitation is? Is it because there's not a peer-reviewed study?
Correct. Although, okay, if you talk about peer-reviewed study, the correct answer is this. There's no peer-reviewed study on patients who received it and the outcome. And it's my fault. I should have published it.
Well, yeah.
But there is a study, more than one study, on the effect of intralipids on natural killer cell level activity. That exists, many, not just one study. Before I began to give it, I checked the literature, and it was clearly shown that when you inject intralipid to either animals or humans, the natural killer cell activity drops, and that drop continues for up to 4 to 5 weeks before it returns to normal. And that's why I repeat that course a couple of more times, 4 weeks apart.
Mm-hmm. I like the protocol. You know, inside my SEED program, the online program, I recommend foods that are high in good fats as they're doing the stimulation protocol. And each of the 4 phases of the menstrual cycle has a different kind of food thrust idea for supporting the hormones. But in that stimulation window, these good fats, they support what the body is naturally doing, which is 1 egg or more are plumping up in response to estrogen. And as the follicle gets bigger, then the estrogen goes up. So it's a cholesterol week, right? Or 12 days, whatever. So I think of good fats that calm, because they calm the nervous system somehow, but I don't know the mechanism. Do you think that it's the fatty acid? Like, what is it about that? I know the structure of a fatty acid is like a, like globule, and it's
the disadvantage you have is that you can give those fatty acids in a nutritional way, and that has an effect. But the effect is incomplete unless you give it into the vein.
Intravenously.
And you obviously are not able to do that. But you have the right idea.
Mm-hmm.
It's just somebody has to continue that idea and implement that in an intravenous way.
Mm-hmm. Yeah. So it's fascinating. And it's another one of these many things that have come along from you being curious, you taking a chance, right? What other kinds of situations have intrigued you and you ran with that's made a difference?
I would say, well, most of the stuff that I will talk about is quite widespread and well researched and known. But if you want to talk about things that are a little bit outside the box, I would say this. For example, DNA fragmentation in the sperm, because we talk about women, but not to forget that you need the men too.
Uh-huh. Right.
And oftentimes we research everything about the woman, and then we forget that there's a man next to her that contributes just as much genetically. And the sperm DNA fragmentation is one such thing that has been ignored for the most part. This was not my idea. It was an idea that came up, I'll tell you exactly when. It came up exactly around 2001. And why do I know that? Because after 9/11, there was a conference in Florida, a big conference, ASRM conference in Florida. And almost nobody went there after 9/11. They were scared of flying and so forth. But I went there. And I had the privilege. It was usually you see 5,000 people there. There was not even 1,000 people. It was half empty. And I could just cruise along and look at things at leisure without a crowd. And there was this one paper, the one poster that talked about DNA fragmentation in the sperm. For the first time I ever saw that, and how it can affect success rate with in vitro. And I was impressed by the research. And I came back home and began to send to that center, I began to send to that lab, male sperm that I was not sure what happened there. I sent them some male sperm for research, for investigation, and some of them came back with elevated DNA fragmentation that explained everything. Again, that's another aspect that was resisted by clinics for many, many years. For 10 years after that, I was probably the only one doing that here.
Mm-hmm.
Of course, now almost everybody does.
It's still
20 years some later.
It's still kind of hard to get a DFI.
Still hard to get DFI. But it took a while for people to start using that test. And yet it's so important. It can explain a lot. And most importantly, it's treatable.
Mm-hmm. Easily treatable.
Easily treatable.
It just takes some time for the sperm to recover using an antioxidant protocol.
Yeah, antioxidant. And when that fails, you can do TESI procedure and retrieve the sperm from the testicle.
Mm-hmm. So we have a story, and I put this in my book, Stick It To Me, Baby. There was a couple. They were your patients. She called me and said, I'm preparing for an embryo transfer. I want to book you to meet me out there. And I said, well, I like to meet the patients beforehand so I can figure out how I could be the most help. Well, she had time on her side, sort of. So she came out to meet me, and she said that her husband, the two of them had done IVF a few times with no success. And they adopted a son. And then she came to me and said, now we're going to try IVF again. But my husband's sperm is fragmented in 57% of the strand. Yeah. So I said, okay. And she said, what my doctor wants to do is he's going to, because I make a high number of eggs, he's going to take half of my eggs and fertilize them with my husband's sperm, and the other half will be fertilized with the donor sperm. And we had the chance to work together. He started his male vitamins. None of us knew how quickly it would take for the impact to change. I worked on her psyche, which was to help her to think differently than she told me, I'm never going to get excited about something, then I won't get disappointed. And I said, whoa, how about thinking different this time and say, like, I could think positive. I can look at what is working, and we have our son here already, whatever, like that. It's like a positive thinking example. But the data points is that 4 sperm from the husband and 4 from a donor. And in the Petri dish, it was the donor sperm embryos degraded, but 2 of the husband's sperm persisted. You put them in, She worked on her positive thinking and it worked. Then 2 years later, she came back.
You know what? I had a similar experience as you just described.
Well, this was
That's what I'm
your
laughing
patient.
Oh, that's
It's
why.
your patient.
There you go.
Yeah, so this was your patient. So she had 4 that were with the husband and 4 with the donor sperm. The donor sperm did not progress, and the husband's sperm did.
Yeah,
she got
I
pregnant.
remember that.
She came back and she wanted to try again. And then she was like, oh, now the pressure is really on me. And I said, or a reframe. You say, now I remember that this is important for me to think positive and look at what has worked. So at this point now the DFI was like 25%. So the antioxidants were working.
Absolutely.
They did another IVF. She got pregnant again. And then there was another one, like another 2 years down the road. And his DFI was like almost minuscule. And again, it worked. So correcting that DNA fragmentation, he obviously stayed on his antioxidants, but also the couple just became happier people from being parents and having these healthy kids. The siblings to the adopted son that kind of cracked their heart open. But that case was so outstanding. I remember just thinking, I can't believe it's working.
If there's any proof that correct nutrition and lifestyle makes a difference, this is definitely one of the most striking one when it comes to DNA fragmentation in the sperm. No question about it.
Yeah, it's just now the men are willing to take the antioxidant vitamins. I think that if they would come in for acupuncture, we could get faster success maybe because
I believe that, men. Well, with men, if the reason for that is something they're taking that they're not supposed to take,
right,
or that it's harmful, well, that if possible, that should be eliminated. Some of them smoke pot a lot, and that can affect it if they can stop smoking pot. Some medications they take may be difficult to take them off, but they can definitely contribute. For example, hair loss medications can cause this. And when I tell guys, when I check with guys, I said, do you use hair loss medications? And he said, yes. I said, can you stop it? He said, really? I'm going to lose my hair. I said, how about you stop it for 3 months, freeze your sperm, and go right back on it. And then in the meantime, take the right nutrition and so forth. So sometimes it's hard to convince them to do certain things. But if you tell them that it's not for a long time, if they can do it for enough time to just improve the sperm and immediately freeze the good sperm so they can have it forever, that would be a good idea.
Yeah. Well, this is a good segue into fertility or infertility, rather, subfertility as a biomarker of humans' health, particularly the men. Here's the women. They're getting their teeth cleaned. They're doing all of their appointments. They are going for relaxation. They're working on themselves. They take so many supplements, self-care, yoga, all the things. But their male counterpart is busy making a living. I mean, she's making a living too, but he's not typically doing stress reduction, or he'll eat whatever is put in front of him, like a different mindset. And I don't know if you know Dr. Paul Turek, but he's a male urologist, and he's leading like the loudest voice about infertility as a male health biomarker. He says that IVF, and particularly ICSI, is the worst thing that could have happened to the male population.
That's in a way correct, because now you can solve all those problems easily.
And their health is potentially declining or not being addressed, their health concerns. What kind of health concerns do you think they should be maybe looking at before infertility shows up?
Well, I've been around long enough. I'm talking about really long enough, half a century almost, to see the decline overall in sperm parameters in men overall. I used to see men with low parameters occasionally, but now half the male that come have parameters that are below. In fact, they already lowered the standard of what is normal concentration, and still they fall below that. And I was been wondering over many times what happened in the past 20, 30 years to cause this? And I came to the conclusion that, yeah, stress is one, but stress was always there. You know what I think? I think part of it is weight. More men are overweight, and being overweight affects the sperm in many ways. So nutrition comes into play, obviously.
Having sugar, Starbucks,
yes,
but they're also more vegan or vegetarian. So there's those men are too thin.
Yeah, that I don't know. I'm not in a specialty like Dr. Turek is to answer those. But I'm just trying to, I mean, my specialty obviously is infertility, and it involves both of them, but it's emphasis on female infertility. When it comes to male infertility, I know enough, but I don't claim to know as much as Dr. Turek does. But I came to my own conclusion that one of the reasons should be simply the weight gain over the past couple of decades must be a contributor, because with weight gain, with reduced health in general, but also with weight gain specifically, temperature around the testicles increases, and that is the known negative for sperm production. There might be other reasons. For example, I think there's more intake of different medications by men than there used to be. I gave you an example of hair loss medication. I'm sure that's something that's more widespread now than it was 30 years ago, if it even existed. So there are certain medications that exist that could cause that as well. Smoking pot is more widespread. I think there are certain aspects of lifestyle that have evolved over the past 2 or 3 decades that have contributed to that. But there might be other reasons that I'm not aware of.
Right. Well, hopefully there will be more studies. And I know there's a book out called Countdown. Do you know that book? Countdown, meaning the counts are down. They're going down.
I get it.
But on a lighter note, one of your patients' husbands wrote a book called How to Make Love to a Plastic Cup.
Correct. Yes.
And I have mentioned that book on this podcast because
that was a funny one.
It's a really funny one. And I think the listeners should know about it if they're dealing with male factor fertility, or if they're a husband. I mean, if they're going through infertility, subfertility, it's good to keep some levity and to hear his thoughts on what's going on, because his voice isn't loud enough in this field. So as we wrap up, I wonder, is there anything that you would like to share as like just a pearl of wisdom that you haven't already covered? You've already given so much good perspective.
Yes, I think. Let me say this. I have a 13-year-old daughter. When she's 21-year-old, I'm telling her to freeze her eggs. I believe that the best way to bank your fertility for the future is to simply freeze your eggs or embryos if you're a couple as soon as you can, as young as you can, because eggs frozen in the 20s or embryos frozen in the 20s will practically guarantee your fertility for the future. If you happen to be in your 30s, still fine. If you don't think that you're going to get pregnant sometime soon, go and freeze your gametes and guarantee your fertility, because it tends to decline very quickly after 35. So that is, I think the public nowadays is quite aware of it. 5 years ago, I had to struggle to find somebody who is even aware of all these things. And somehow I find that more and more, many more are aware of it these days and are seeking that kind of help. But still, there's some degree of ignorance in that respect. And I think people should be aware that that is available and that they should take advantage of that.
They should also, I'm sorry to interrupt you, but as Dr. Kelly Beck has said, the egg freezing is definitely not to be viewed as an insurance policy. And so my add to that is the more that they can optimize their health, the more they can feel pretty good about what they've put in the freezer. So like if you're 18 or 21 and you're pretty healthy with food, then really think about preparing your body for a couple of months before doing that egg freeze.
Absolutely agree. You should be in your best place possible, but if you're young and you have time to take care of that, if you can lose some pounds, if you need to, that would be good, and so forth. Yes. The other thing, okay, so that about freezing, definitely there's no question that this is the way to go if you're not planning to get pregnant soon, in order to not find yourself one day unable to conceive and then necessitating egg donation. And then the other advice I would give is the one that we started pretty much the conversation with, and that is that if you were given an opinion that you cannot conceive anymore because of your ovarian status or your age, don't act on it until you receive the second and even a third opinion, because there's so many pathways that you can choose that might actually get you to your goal if you just researched enough. Mm-hmm. Not the least of them is, of course, calling the well people integrative healing center.
What I like to say is that a lot of the times we can become more fertile over time when we change our trajectory to think healthier, eat healthier, live healthier, and calm down.
I agree.